Mutational landscape of AML is important in a way that over the last years we learned that mutations are important with regard to how patients respond to the treatment with chemotherapy. Recently there have been new mutations identified where we know that patients then do not respond at all. For example, if you have mutations in classical tumor suppressor genes such as p53 or mutations in epigenetic genes like ASXL1 or transcription factor RUNX1. Those patients, for example, we now would move forward with more experimental therapies or transplant strategies. In addition, one also has learned that the mutational load is important. For one of the most common mutations in AML, mutations of the tyrosine kinase FLT3, we know that if the tumor cell has many copies of the mutant gene, it responds worse to chemotherapy, and there we are now in a lucky situation that we have a targeted therapy, a new kinase inhibitor called midostaurin, which we can use for treating that disease. There's also mutations now which can be targeted by new substances. For example, IDH mutations can be inhibited by small molecules, and then also there are new substances that, for example, impact on apoptosis, and I think those would be good combination partners with the gene mutation targeted therapies with these more global new strategies. So there, the problem was for AML that over the last years not so much was changing. We are still using the same chemotherapy backbone, more or less. There was some epigenetic drugs that became available, but now with the kinase inhibitor, the first targeted therapy, we for the first time could improve overall survival in our patients. And I think that the new combinatorial strategies where we combine chemotherapy with targeted therapy, with epigenetic treatment strategies, and hopefully soon then also tumor immunological approaches, I think those will then really be of tremendous benefit to the patients. So what we also know, or what we have learned over the last years, that the genomic landscape is also changing and different in older patients than younger patients. If we understand the differences better, that also might help us to better treat the disease. We also know that very often some of the clones persist in the patients, malignant clones, who later then will give rise to relapse. We will have better strategies to monitor that minimal residual or persistent disease, and also use then tumor immunological approaches to get rid of these clones in the future. So the take-home message would be that it's interesting times with the new technologies at hand. We really can now capture the heterogeneity between individuals, but also within one individual. This allows us to develop better tools for monitoring the disease and then ultimately also cure the disease.